Hi, this is Amna, optometrist from Global College of Allied Health, Nattalam. Today the topic is hypertensive retinopathy and diabetic retinopathy. Hypertensive retinopathy. In systemic hypertension, it is important to consider two aspects separately by severity and duration. The severity of hypertension is reflected by the degree of hypertensive vascular changes and retinopathy. The duration of hypertension is reflected by the degree of arteriosclerotic changes and retinopathy. Classification. There are two types of classification. First is Keith-Wagner-Barkan classification. Grade 1 shows mild generalized arteriolar narrowing. Grade 2 includes more narrowing of the arterioles and also focal arteriolar attenuations, arteriovenous crossing changes. Grade 3, Grade 2 changes with hemorrhage, cottonwool spot and exudates. Grade 4, all the three changes of the grade 3 with papilledema including neuroretinal edema. The second classification is Shee's classification. Here, the retinal changes of hypertensions and arteriolar sclerosis and graded separately. In normal fundus view, there is no ophthalmoscopic retinal changes. Grade 1 shows gun narrowing of a smaller retinal arterioles. Grade 2 includes severe narrowing of localized irregular constriction of the arterioles. Grade 3 shows irregularities of the arterioles with retinal hemorrhage and exudates. Grade 4, all the changes in grade 3 along with the neuroretinal edema and papilledema. Treatment. The treatment of the hypertensive retinopathy is necessarily control of hypertension and that of underlying disease. The next is diabetic retinopathy. The severity of the diabetic retinopathy generally parallels the duration of the disease and the adequacy of its control and not the severity of the diabetes. The incidence of the diabetic retinopathy is more with IDDM than with NIDDM, but the severity of maculopathy is more with NIDDM. Clinical feature shows microaneurysms, dot and blot hemorrhages, flame-shaped hemorrhages, hard exudates. Types. There are two types: pre-proliferative diabetic retinopathy and proliferative diabetic retinopathy. In pre-proliferative diabetic retinopathy, it develops in some eyes. Those initially shows only a simple background retinopathy. All the lesions are caused by retinal ischemia. Clinical features shows cottonwool exudates, intraretinal microvascular abnormalities, venous changes, arteriolar narrowing, dot, large, dot blot, and hemorrhagic retinal infarcts. The second is proliferative diabetic retinopathy. PDR affects 5% of the diabetic populations and more with the juvenile onset diabetes. Clinical feature shows neovascularization, posterior vitreous detachment, hemorrhage, tractional RD, neovascular glaucoma. Management of diabetic retinopathy. The first is general management, metabolic control, control of hypertension and anemia. Visual defects, transient variation in refractions. In hyperglycemia, increased refractive index of the lens has myopic shift. In hypoglycemia, causes decreased refractive power of the lens, which leads to hypermetropic shift. Photopsia and diplopia in cerebral hypoglycemia, decreased accommodation. Diplopia in ophthalmoplegia caused by neuropathy, decreased vision in cataracts, maculopathy, and vitreous hemorrhage. Complete blindness from tractional retinal detachment, massive vitreous proliferations, and neovascular glaucoma. Ocular movements. Neuropathy with muscle paralysis, painful ophthalmoplegia. Lids have increased incidence of stye. Conjunctiva shows tarsius and constricted blood vessels. In cornea, there is delayed epithelial healing due to the epithelial basement membrane abnormality. Punctate keratopathy, increased incidence of infective keratitis with delayed healing, wrinkling of Descemet's membrane, decreased corneal sensation, increased prevalence of the dry eye. In Irish cases, hydrops of the pigment epithelium, rubiosis iridis, vitreous causes vitreous hemorrhage and fibrovascular proliferation in the vitreous. Retina has diabetic retinopathy and central retinal venous occlusion. Intraocular pressure is increased in neovascular glaucoma and increased incidence of primary open angle glaucoma. Thank you.